Hi everybody. We're just going to give people a few minutes to get on, just to see if anybody's out there listening tonight. There might be like 2 of you. I know it's like right at the end of the day. What a good time to talk about donors, right? So, my name is Courtney. Give me 1 second here. I'm just going to turn my computer off. There. So my name is Courtney. I am one of the donor coordinators here at ICRM. Shauna Bennett is my co-coordinator. She coordinates for Dr. Tobler and Dr. Moss. I coordinate for Dr. Slater. And then running the camera tonight is Maddie Gortat, who is our intake for donors. She does our donor recruiting. She is our all-around superstar for scheduling for the third-party program. We can't live without her. So they asked me to do a live tonight just to kind of talk about some of the common questions that we have with the donor process, what it's like when using a donor, what to concentrate on, and things like that. So for those of you who know me, you probably know that I'm really quite visual. So I'm looking for my dog-eared little presentation piece that I use a lot of the donor, or of the ovaries. Oh my gosh, did I lose it? Well, I guess maybe I won't have that today, right? Okay. I guess I'll use something else today.
I moved a couple things over there as well.
You what?
I moved a couple things over there, so hopefully didn't.
Let me see. Because I love to have, everybody who knows me knows that I love to collect paper like a job. It's like my favorite thing to have. Ah, there it is. I can see now. Okay. So, sorry about that. Okay. So, just to give you some background, so we do have an in-house donor program here. We have anywhere from 70 to 100, 115 donors that are either available or going through cycles at any given point. We do have a really good donor selection. We try to make it as variable as we can. Some of the screening things that you can see in our donor program are, for example, when you log in and you're looking through donors, that you can screen for a 2-daddy donor or a 2-sperm source donor. So we'll talk about that in a minute. And I'll talk a little bit first about the donor screening process. So the first thing that we do, I know that I'm quite the artist, everybody, just fair warning here. So the first thing that we actually will do is we'll look at the ovaries of the donor. And so what we're looking at is we want to look at their ovarian reserve. So we're going to count the number of follicles that we see at rest between both ovaries. The average counts nationwide will be about 15 to 20. For our 2-daddy donors, as we say, that's for our same-sex couples, we're trying to get a little bit higher of a number. So we're trying to just be able to get both genetically represented. So we want to see numbers closer to 20, 25 or higher. So the average is about 15 to 20, and I don't know if you can see, but it probably looks kind of pink around these circles. Those are the follicles that house the eggs. And so around each of those follicles is a hormone that's being secreted called AMH, or anti-Mullerian hormone. And that stands, AMH stands for anti-Mullerian hormone, like I said, benefit of alive, right? And so that is kind of an ovarian reserve marker. What I always tell donors about that one is the higher the number, the cheaper the date, and that just has to do with the medications and how much they'll use on a cycle. When that number is higher, it just helps give us an idea that her body's going to respond to those medications and understand what we need it to do. We'll also look at, their BMI. We will do a drug screen and a nicotine screen. We'll get their blood type, we'll do a CBC, and then we do a really large genetic panel. So we test for 283 conditions. I'll take you all the way back to 8th grade biology with the Punnett squares. And we just really want to make sure that you and the donor don't carry the same condition. That's really what we're looking for. We all carry something. We are looking at a panel that's 283. There's 20,000 genes in the body. And so you're going to carry something. We just want to make sure it's not the same thing. I frequently have intended parents who think that having a donor who's negative is sort of like, as I say, a promise that their donor's negative for everything, and it's not. That's a much more complex conversation for a different day. On that panel, we'll also test for 20 X-linked conditions as well, and those ones are a little more in-depth and, as I say, dangerous, just because they can pass generation to generation. So we typically don't keep donors on the list who carry something that's X-linked. The next thing that the donors will go through is they'll go through a psychological evaluation. So we're going to look at it looks for signs of sociopathology, psychopathology, make sure they understand their decision. Talks about the idea of contact in the future, just because there is going to be children someday who may be curious. We do talk somewhat about donor sibling registry, which is a way for donors and intended parents to be in contact if they so wish. I'll talk about that some other time, just to not get too in depth on a quick live. And then once they've gone through all of those screening things, then that's when they're essentially cleared to do a cycle. And so some of the most common questions, and we do get these a lot, I printed them out just so that I could reference them. One thing that we do get asked a lot is if people worry if they should, or wonder if they should worry about their donor's blood type. We are not necessarily concerned with the donor's blood type or mixing with your blood type or the surrogate's blood type, in the mix. What we would focus more on is the surrogate's blood type, and we don't even look back at the donor's blood type at that point. If she is Rh negative, we would just go ahead and empirically treat, and there is treatment methods out there for that. So in the grand scheme of things, that's low on the list of things to worry about. So I wouldn't worry about your donor's blood type or the mixing of blood types. That's just not something to focus on. Another one was, on how can we know if a donor will be good? And so that really comes down to those ovarian reserve markers. So when we see that number of follicles at rest, so when you hear us say like we see 15 to 20 at rest or 20 to 25, that's the number of follicles that we expect that we would be able to stimulate and then to be able to retrieve the eggs from. Anything above 20 is just sort of a bonus, as I say. Sometimes we do have donors who make enough that they couldn't even be split donors. That just means that they make so many eggs and have such a high conversion ratio of that egg to blast that, as much as we want to help you have your family, we don't need a whole football team. So it just helps to be able to help two families at the same time. Another one was, are frozen eggs as good as fresh eggs in terms of cycle results? So they are essentially yes. So there's benefits to both. With frozen eggs, it means that you have a more immediate availability, that you have like a fixed number, so you know that there's eggs available, and that you're not waiting for a donor to respond on if she's available or to find out on certain things, that everything's ready for you to go. But when we see the frozen eggs, you're going to usually get one lot, or a lot is about 6 to 8 frozen mature eggs. And sometimes in the thawing process, we can lose some to attrition. So we may not end up with 8 eggs. It may be that 6 survived the thaw. So you're already at such a smaller finite number that we're wanting to increase your chances. And so that's kind of one of the benefits of a fresh cycle, is just that you're going to hopefully at least get more than 6 to 8 eggs. So that'll hopefully increase your chances. But in the grand scheme of things, we do see success with frozen eggs as well as the fresh. And then somebody had asked, should I be concerned about the donor's family medical history? So all of the donors, when we look at their family medical history, we're going to be looking to screen out anything that we know that is heritable or genetic or increasing risks. So the biggest example that I can give is if a donor comes in and knows that there's a family member who is positive for the BRCA gene, which is the aggressive form of breast cancer that does have that genetic component, she would not be able to be a donor, just because that goes down at a 50-50 mark through the generations. I lost my train of thought there. And so that's where, when it's going to be heritable at a 50-50 rate, that risk is just way too high. Every family is going to have some history of something. What I always say is that, when you go on a date with your partner, at least when I've been on dates, I have not asked things like, hey, so who in your family has had strokes or heart attacks or cancer or diabetes? The big ones that we look at are, if there is a history of cardiovascular disease, diabetes, mental health, substance abuse, and then also for the diabetes and then cancers. Those aren't things that we would ask our partner when we're screening our partner. There's going to be nobody who has a completely clean family history. If they do, then that's probably going to worry me more than if there is a few things, just because, nobody's going to be completely squeaky clean. So we're trying to screen out as much as we can as far as the heritability component. So any donor that is on the list has been cleared and accepted by the physicians and by ICRM to be able to be a donor. One of the other ones is, if my donor has blue eyes, will my child have them too? This is such a common question. We have so many intended parents who love those donors with blue eyes. What I always say with that is genetics are complex, so we can't ever guarantee what we see as far as the phenotype. So phenotype is what is referred to as what is displayed. So that would be like the hair color, the eye color, even height can be a phenotype. We can't ever guarantee those, so I would say that I wouldn't use that as a way, thinking, well, if every person in her family has blue eyes, then my child will have blue eyes. That's not necessarily the case. We just care about getting you a healthy, happy baby in your arms more so than the eye color. And then, should I care about the height of my donor? I would say right up there with the eye color is that height. We have lots of intended parents who love those tall donors. I always say, just because the donor is that tall doesn't necessarily mean her kids will be that tall. I would also look at the family, height, the history, family's history and their height within there that is displayed in the profile. Just because, maybe that donor is the shortest one in the family. Maybe she's the tallest and she, at 5'10", everybody else is 5'6", or vice versa. So, it's not necessarily a guarantee of any type. I would say that the other common question that I saw was about the embryo adoption program. So with the embryo adoption, we actually refer to it as embryo donation. So the embryo donation program, the list is about 2 years long, and I really do love that program because it really does give some families the chance that they wouldn't have had otherwise. Our embryo donation program is anonymous here in-house. So when a family has leftover embryos that they know that they're not going to use, they do have the option to donate those to other couples anonymously. They'll do a profile, whether it's an egg donor that they used and then whoever the provider of sperm was, or if it's, the egg is from the mother and the sperm is from the father, they'll do a profile, and then usually the embryos are split into lots of 2 to 4 depending on the case. Those ones are really beneficial because couples will wait up to 2 years for those, and it's really sometimes their only means to be able to have a family. They'll also go through psychological screening, and then I typically think that there is a contract involved, and I would have to confirm on that one, but it really is a great way for some families to be able to build their families, especially if they can't afford to do the IVF process or the donor process, because as we all know, this is super, super expensive. The other thing with donors that I would talk about is with the ASRM guidelines. So the ASRM guidelines say that donors can do up to 6 cycles in a lifetime, and so that's when we'll retire them. We also will use donors from the age of 21 to 34, and I think that a lot of intended parents will sometimes decline a donor who is above the age of 30 or approaching the age of 30. And honestly, what I always say is that I sometimes prefer my donors who are a little closer to 30, and I think that's just because they've matured a little bit more. They understand, who's on the other side of this process, and that it is very serious. So I definitely wouldn't decline a donor just because she's close to the age of 30. We've declined donors who are 21. It doesn't necessarily mean that at 21 that they have more eggs than a girl who's 30. Every donor's body is different. So age is another one that I would say to not necessarily focus on as far as something to decline a donor. And then if you reach out to your coordinators, then we can also make some recommendations as far as looks. And then actually the other one that I would say is ethnicity. So for Caucasians, I think a lot will screen just in the Caucasians, but I would actually leave that filter off. The reason being that there are girls who are multiracial, but they have a very Caucasian appearance. So maybe, one parent is Hispanic or Latino, and then, they have another parent, their other parent was Caucasian, and they, are blonde haired and blue eyed. And so sometimes those donors sort of seem to skate right under the radar and not be seen. And then that one, that's how you can end up sometimes getting a superstar out of it. And then, looking at that previous history, if a donor is proven, that really is what can help give us that, as Dr. Moss says, that future success correlates with the prior success. So it just helps us to be able to see if she's had a previous cycle. We really can look at those cycles to see, did she do well? Did she not do well? Do we see something that maybe could have been corrected? And maybe it was a sperm factor in that case, or, you know, if she's had a few good cycles, if she's had previous pregnancies of her own. Those really are the benefits to using those in-house fresh donors is, you know, we've got a full history on them. They're almost all of them are here locally. We've come to know them quite well. They really do care a lot about their success rates with their intended parents, and I can't tell you how often that we have donors who reach out and say, hey, did anybody get pregnant? I actually just saw a second ago that I had a message from another donor saying, do we have any news? Is anybody pregnant? And that's really just because, as I say, knowing if it was successful for you really is that final chapter of that book, of that cycle. So they really do care about having success for you. They know your hopes and dreams are riding on them, and they really want to do well for you. Those are probably my biggest things that I would say to look at. Oh, I guess I forgot one other question. What do I want to look for in a donor, and what should I concentrate on was the other question. You know, that's a really very personal choice. I would say, you know, personality and everything aside, just looking at the medical aspects, you know, to look at if we've decreased as much as far as the risks of heritability, so anything in the family history, and then if there are previous cycle results, or how her ovarian reserve looks, and the genetics are compatible. Those are the things that are really going to be your cornerstone, and then you can build the rest of that house of your donor based on that. So, you know, personality wise, do you want somebody who's more introverted or extroverted? We've met each of the donors in person, we know them well, and that's our goal, is to be able to give you a donor that, you know, you really do feel like you've got a good understanding of who she is, what her personality is like, and that you feel represented, or that she's the one, as I say. And that really is the benefit of that in-house program here. And I don't know, I know I talk really fast, I always say that, it's kind of my superpower. I don't know, do you have anything, is there anything else that I should cover, Maddie?
I think that was everything.
I know that I talk really fast, it's kind of a problem, so. If there's any questions, please don't hesitate to reach out to Shauna or myself, or if you are a woman who's interested in donating your eggs, reach out to Maddie. Our emails can be found on the website. If you're interested in donating your embryos, then you can email Sabrina. We always love couples who are ready to donate their embryos. Of course, once you're done building your family, but that's another way to be able to pay it forward and help people have their families because they wouldn't otherwise have them. I'm so blessed to do the work that I do, and I love working with my couples, both locally and all over the world. And I am recently passing a law that I'm calling Cortney's Law, because I'm just gonna do that, and I'm tired of not seeing my babies, so please send me baby photos. I miss getting to see our babies and hold them and give hugs, so send us lots of baby photos. We love that so much. And if you have any questions, just reach out, and we look forward to hearing from you.